Thank you. Hello, I'm Dr. DeSchavo. I will be lecturing today about the skeleton. We've already talked about the tissues of the skeleton and the cartilaginous skeleton as a precursor to the skeleton. Today we'll be studying the structure of the bones and the different parts of the bones. Many of these structures we will specifically go over in lab. Many of these structures I've asked you to prepare on your preparation. Those parts are totally fair game for lecture tests. I'm not going to sit and specifically go over every single part, but there are some concepts that I would like to review with you with the skeleton. Okay? Moving on. There's axial and appendicular skeleton. Appendicular is the appendages, the arms and the legs. That also includes the shoulder girdle and the pelvic girdle, as opposed to the axial skeleton, which would be the axis of the body. So that would be the skull, the vertebra, the ribs, okay, and the tailbone you could include. Okay. Cranium is going to be all the bones of the skull. We've got the large bones of the skull that begin actually as separate bones in utero. They actually start as a membrane, okay, and then they start to ossify or calcify. And all these separate bones, eventually those ossification centers get closer and closer until they actually fuse together, and all those separate bones become the nice, solid, complete cranium. If we take a look at the example up here on the board, we've got the frontal bone, which is towards the front. We've got the nasal bone, which is an easy one, right where the nose is. The maxilla will be the front part of and the top part of the mouth that the teeth are in. The mandible is the bottom jaw. The zygomatic bone is going to be the back part of the cheekbone and towards the back of the face. Parietal bones are the paired bones on the top of the skull. Occipital bone will be the one at the base of the skull. Okay. Once again, I'm buzzing through these because we'll definitely go over them in lab. So that is the external bones of the cranium, but keep in mind that there are bones on the inside of the cranium as well, such as the ethmoid and the sphenoid, which we'll go over in class. Okay, you can see this side view once again: frontal, parietal, occipital, temporal bone, which I left out. Of course, it's an important bone. Okay, temporal bone comes to meet with the maxillary bone. Okay, we also have sphenoid. Sphenoid is going to go right across the skull. It looks like a butterfly. You'll notice when you look at it. Mandible, maxilla, nasal bone. Okay, zygomatic bone is going to be the front part of the cheeks here. Okay, maxilla is going to be the top part of the mouth. Just to specify that and clarify that a little bit. Okay, looking at the back, we've got our parietals and our occipital bones. Looking at the inside, the one thing that I want to point out is, here's that sphenoid bone that looks like the butterfly. If you look at this picture up close in your notes or in your book, you could pause this tape, you'll see there are air cells. Within that sphenoid bone, we have sinuses, okay? We'll have sinuses that we'll talk about in a little bit. I just want to point out this is a great picture of those openings or those sinuses in that sphenoid bone. Okay, looking at the bottom, the thing that I really want to point out in the bottom, we have all those bones once again. We're transposing this image, so we're looking at the skull from the bottom. In the occipital bone, we have a very large opening. And if you think for a minute, I bet you can imagine what that is for. That is called the foramen, and foramen means an opening or a hole. Magnum, which means large, okay, large hole. And if you thought about it, I wonder if you can guess what passes through there, and our spinal cord passes through there, okay, which heads down to the center of the vertebra and out to the entire body, okay, sends nerves out to the entire body. There are different holes that we'll find on the bottom of the skull. Those holes or openings, just so you know, in general, are going to be the entrance or exit site for veins, arteries, and nerves, okay? Internal carotid artery will pass up through the bottom of the skull. Internal jugular will pass down through the bottom of the skull, okay? Nerves go through these openings to all different parts of the face and neck region, Okay, so those holes or openings are for nerves, arteries, and veins. Okay, the different bones of the orbit, you could see, makes a complete boundary for the eye, because the eye is pretty delicate. If you remember our dissection from mp4, it needs to be held in place. I do want you to look back at this opening. This is the optic canal. This would be where the optic nerve passes through, okay? Has a nice bony protection for it to keep it safe. Okay, so optic nerve is going to be in the back of the orbit, and it actually passes through the sphenoid bone. Okay, here are those sinuses, and sinuses are very important for a clinical reason, and if you think of that clinical reason, they can get infected. Okay, there are 4 pairs in the frontal bone. You can see here, and you can see here. Okay, we have sinuses. We have them in the maxilla, and these are actually pretty large, these maxillary sinuses. And when they get infected, you can really feel that pressure underneath your eye. Some people feel it as pressure in their teeth. Deep to the maxillary and the frontal, so deeper into the skull, we've got sphenoidal and ethmoidal. Those are sinuses. They can also get infected. More commonly, we will feel those infections in the frontal and the maxillary. Okay, so 4 pairs of sinuses. Okay, and here's a better picture of this. Okay, hyoid bone is the only bone in the body, other than a sesamoid bone, which is not going to be directly attached to another bone. It's in the throat. You can see it moving when we talk. And what it does is it provides a site of attachment for muscles, okay, for vocalization. Okay, there's a picture of the hyoid bone. Vertebral column. The vertebral column will run from the base of the spine all the way down to the sacrum, which is your tailbone, okay? There's cervical region, there's thoracic region, and there is lumbar region, which is going to be your low back, okay? So cervical, thoracic, and lumbar. Some people remember the number of vertebrae by a silly little mnemonic, okay? Cervical, thoracic, and lumbar vertebra. So the silly way to remember the amount of vertebra at each one of those levels is by the times you would eat breakfast, lunch, and dinner, okay? So we eat breakfast at 7, we eat lunch at noon, and we eat dinner at 5. There are 7 cervical vertebrae. There are 12 thoracic vertebra. Let me pull that in a little bit closer. Okay. Oh, there we go. Okay. So 7 cervical vertebra, 12 thoracic vertebra, and 5 lumbar vertebra. Okay. Now, there can be variations in that, but that is in a normal, common spine. Okay. So cervical neck, thoracic, and lumbar. Okay. It's important to know the levels, especially if you get into a pain management group. You need to know the amount of vertebrae at each different levels. It's also important to know because many people get herniated discs, and we need to know the levels at which those herniated discs exist. Okay, so 7, 12, and 5. Okay, now the main difference, other than location, that I want you to keep in mind is in the thoracic spine. What do we have attached to those thoracic vertebrae? Think for a minute. We have the ribs, okay? So each one of those 12 thoracic vertebrae will have ribs attached to them, okay? So it helps to increase the resiliency and flexibility of the spine. If you think about it, the spine has, from the side, nice natural curves to it. Okay, those curves act as a spring to give us some resiliency when we are giving stress through our body, and a little spring to resist any compressive forces. Okay, from the front, the spine should be straight up and down. There are different curves that we will see in the spine. I'm going to move in on the whiteboard. Okay. Once again, I'm not an artist, so don't expect much from this. And everybody always laughs at this. Silly little drawing. Okay, that's the nose, that's a head. If you look at the cervical spine, thoracic, and lumbar, and here's the tailbone, okay? Those nice natural curves actually have names, okay? When the curve moves forward, it is called a lordosis. Okay, so lumbar and cervical spine both have a lordosis. Okay, when the curve moves back, it's called kyphosis. In further on in the notes, I actually have an explanation as to why those happen. Okay, when we start as a newborn, we don't have these curves yet. As you start to crawl as a newborn, you lift up your head and you start to get that nice curve forward. Okay, as you start to learn to walk, you stand up and you start to get a nice curve in the low back. That'll help to give us that springiness to the spine. Okay, unfortunately, over time, what do we do when we study? What do we do in class? We sit with our heads forward and we start to lose that curve. And everybody wonders why they have neck pain and headaches. It's because they're losing that curve in their spine. So one of the things that you can do clinically to treat this with people is to have them start working on exercises to bring the shoulders back, to bring the head back over the spine. I can totally teach you those in lab if you want. Okay, so just let me know. Okay, so this is normal, having these two lordotic spines, the kyphosis. Some people consider this a kyphosis as well. Okay, a little bit of curve back of the sacrum, if you couldn't figure out what that is. Okay, there are abnormal curves in the spine. Well, I have you on this picture. If you think about your great-grandma Edna or your great-grandma Ethel, okay, they were both my grandmothers, by the way. As they age, instead of having the head over their shoulders, what happens? Right, they get that forward posture, okay? So kyphosis references just the normal curve of the thoracic spine, but we also use it as a differential diagnosis, calling people kyphotic when they have an accentuated thoracic curvature. Okay, that's right in the notes. I believe, yes it is, okay? So kyphotic. We can also, if you think of gymnasts, okay, if you ever watch the Olympics and you watch gymnasts, they get that real accentuated arch in their low back, okay? That's called lordotic. And it can actually, it is a normal term, but it can be used as an abnormal term as well. And that accentuation can actually put excess stress on their lumbar vertebra. Okay, they can actually fracture over time. Okay, so kyphotic is an increase in that thoracic curvature. Lordotic is when you get, it's sway back. Okay, it also happens in pregnant women. Definitely happened when I had my two boys because they put on so much weight. It pulls your belly forward and you can imagine that curve increasing. Okay, the other abnormal curve that I'd like to talk to you about is a scoliosis. Okay, so if I draw once again a great little picture with all my artistic abilities. Okay, so here's our patient. Okay, we should have from front to back a nice straight spine. Okay, what can happen for a variety of reasons? It can be congenital. It can actually be short leg if you're born with one leg shorter than the other. If you've had a severe injury in the leg and it's not the same length as the other. What can happen is you could start to get a deviation from side to side. Okay, so instead of a nice straight spine, it goes side to side. It always goes in an S-shaped curve. Because if you can imagine me standing here, and if I had some sort of injury and my right leg was now short and I started to lean to the side, okay, I would actually lean this way, okay, I would just keep going, right? It would fall over. Our bodies don't like that. Our bodies actually have a neurological reflex which want to keep our eyes level with the horizon, okay? So in compensating for this curve, we will get a compensatory curve back, bringing the head over the shoulders. Okay, it's called the righting reflex if you have any interest in knowing. So with scoliosis, we don't just get a curve one way, we get an S-shaped curve. Okay, so we get that initial curve, why it happens, a variety of reasons, and then a compensatory curve bringing you back up. Okay, so scoliosis. With a patient with scoliosis, if you bend them forward quite often, you have something called rib humping. You'll see that one side of their mid-back is higher than the other. Okay? All right. Intervertebral discs. So between each one of those vertebrae, those bony vertebrae, we have cartilaginous discs. Okay? It has two parts. It has a nucleus pulposus and an annulus fibrosus, excuse me. Okay? If you can imagine that I bring in a jelly donut, and the jelly donut is 10 times harder than a jelly donut, give or take. Okay? It's got a hard outer portion and a jelly type of center, but it doesn't have that little hole where they stick the jelly in. That's exactly what a disc is structured like. The annulus fibrosus is the cartilaginous, harder outer portion. The nucleus pulposus is a gelatinous center, okay? So the discs are a little cushiony pad that helps us to rebound from any stressors that is put through our spine. Okay, so intervertebral discs. If you can imagine that I take that jelly donut and I squeeze it and I squeeze it and I squeeze a little bit harder and I squeeze a little bit harder, eventually the jelly is going to what? Pop out, okay? That is exactly what happens with a herniated disc. There's a bulging disc, there's a herniated disc. So if I keep stressing that jelly donut, eventually the outer fibers are going to break a little bit and it'll bulge outward. That is a bulging disc. If I keep squeezing and squeezing and squeezing and squeezing, eventually probably one area that is the weakest will break and the jelly will pop out. When the jelly pops out, that's a herniation. That's a difference between a bulge and a herniation. There's no slipped discs, it doesn't exist. The discs are pretty solidified, solidly placed between the vertebra. What happens is either those outer fibers weaken and the disc bulge, or you get a popping out of the nucleus pulposus, which is a herniation. Either one can cause problems. Where they like to herniate, if you take a minute and look up this picture in your book, well, actually, let me see if I can get in. Okay, I can't get in closer. But either look in your notes or in your book at this picture. You can see that the jelly has popped back here, and this structure right here is a nerve, okay? This is where discs like to herniate. They like to herniate backwards. It's the weakest portion of the disc, so of course that's going to be where it herniates or pops out and pushes on the nerves, and that's where you get what people call a pinched nerve, okay? You can pinch a nerve other ways, but this is just one example of how you get a pinched nerve. And then you get all sorts of neurological symptoms on the nerve that is pinched, okay? Now, the structure of the vertebra is going to be very different from cervical to thoracic to lumbar, but there's a nice easy transition as we get to the areas right between the cervical and thoracic, and between the thoracic and lumbar. It actually gets hard to tell the difference between them. Okay. But if I were to take a cervical versus a lumbar vertebra and put them together, you could tell the difference pretty quickly. And we're going to look at those specific differences in lab. What I would like to do is very quickly go over the different parts in general of a vertebra. And there's two exceptional vertebrae that I'd like to talk to you about. Okay. So looking at this picture, we've got the vertebral body. The vertebral body is going to be the area between which the discs will be located. Okay. These structures here are called pedicles. It's the area of bone, that bony ring that encircles the, what does this encircle? The spinal cord, okay? So it helps to complete the circle in the front. These are called transverse processes, okay? The transverse processes stick out to the side. They're the site of attachment for bones and ligaments and tendons, okay? Or transverse processes, I'm sorry, transverse processes. This is the spinous process. The spinous process, if you feel the back of your spine, it's the bumps in the back of the spine. Spinous processes and the transverse processes are both areas for sites of attachments for bones, muscles, ligaments, and tendons, okay? Between the transverse process in the spinous process, we have this little part of bone. This is called a lamina, okay? A lamina. The reason that this is clinically important is if you have someone who has a herniated disc and they have a decompressive type of surgery, the lamina is the area that the surgeon will cut the bone away from to relieve some of the pressure on the spine and the nerves, okay? It's called a laminectomy, okay? Laminectomy. So those are in general the different parts of the bone that I'd like you to know. There are articulating processes here. This articulates with the vertebra above, and there's a pair underneath the vertebra which articulate or touch the vertebra below, okay? And they make a column of articulating processes that help us to create a little bit of movement in the spine, okay? Cervical vertebra, C1 and C2 are very different from the other vertebra in the spine, so I'm going to take a minute and go over that, okay? C1 is known as Atlas. Atlas, if you think of mythological Atlas, he held up the world. C1 is known as Atlas because it holds up the skull, okay? Kind of a cool little thing. C2, okay, is known as Axis. So this is C1, okay? And you can see with C1, it does not have a body like we saw in the previous slide. It's just a bony, well, not just, it is a bony ring, okay? These are transverse processes. Here's an opening for one of the blood vessels that go to the brain, okay? This is the back, this is the front of C1 or Atlas. Here is C2, and C2 looks very different. The thing that really sticks out with C2 is this little process called the dens or the odontoid process. And they sit together really well, and I'll show you that in lab. Okay, C2 is known as axis because it provides most of the rotatory motion of the skull on the vertebral column. So when I do this, that rotational movement is happening around the dens or the odontoid process of C2, also known as axis. Okay, good. Okay, C1 through C7, we've covered most of what I want to cover with that. You can see on this picture how C2 sits nicely into the front part of C1, and you can see how the vertebrae are stacked together. There's a very important artery that runs up the side of this called the vertebral artery. And the vertebral artery is one of the main blood supplies up to the brain, up to what's called the circle of Willis, which provides the blood supply for the brain, okay? The reason that's important to know, this vertebral artery comes up and passes through these openings. It kind of takes a little twist right here, whoop, okay? It makes it a little bit more prone to strokes, the way that it's bent around C1, because it makes this little S shape, okay? If you extend and rotate your head, you can actually block off your vertebral artery on one side. Okay, so it's very important not to extend and rotate your head, because if you block that off and you have a blockage on the other side, you can cut off some of the blood supply to your brain. You can also dislodge any blockages that might be in there, right? Thoracic and lumbar vertebrae, I've gone over the major parts of them that I want you to know. I do want you to also know that ribs attach to the thoracic vertebra. I'll show you exactly how that goes together in lab. Okay, sacrum and coccyx, these are considered together the tailbone, okay? They're considered together the tailbone. The sacrum is going to be the majority here, okay? The coccyx is actually 4 fused bones at the bottom, okay? This can be fractured off. It's very painful. It takes a long time to heal. If you see somebody sitting like on a little donut, quite often it's because of this kind of fracture. Fracturing the sacrum is a nasty, nasty thing. If you think of the anatomy of neurology, there are several sacral nerves which will pass through the sacrum, okay? If you fractured this, you could get that disease process called cauda equina, okay? Loss of bowel and bladder control, loss of neurological control of the lower extremities, okay? So sacrum is very important to keep those sacral nerves safe. Okay, bony thorax. So you can see here we're going to talk about true ribs, false ribs, and floating ribs. Okay, True ribs, you might want to pause this and take a closer look at this picture. Oh, I can pull you in. That's right. Okay, hold on just a second. CR? There, perfect. Okay, so if you take a look at this, the true ribs, and if you can't see it, please pause this and open up your book. Okay, so there are 12 pair of ribs. The true ribs are 1 through 7. Some places you'll see 1 through 6. We'll stick with 1 through 7 as the answer to any questions about ribs we have in this class, okay? So they're called true ribs because each one of those ribs, 1 through 7, attach directly to the sternum, which is going to be the breastbone in the front, okay? False ribs are 8 through 12, and if you take a close look at that, they're called false, because they don't attach directly to the sternum. They actually all attach to a common cartilaginous, well, not a common, a few common cartilaginous attachments to the sternum, okay? Floating ribs are called floating ribs because they are not attached to the sternum at all, okay? Floating ribs are going to be 11 through 12. So false ribs are really considered 8 through 12, okay? Floating ribs are 11 and 12. The true ribs are 1 through 7, okay? Excuse me. So the sternum, which we just looked at, is going to have those 3 fused bones, okay? Manubrium, body, xiphoid process, okay? I'm going to back up, okay? So the manubrium is going to be this top part, okay? The manubrium has the jugular notch, which if you use your finger, you could put your finger in the jugular notch at the top of it. And the manubrium comes down and attaches to what's called the body. Now, the reason I wanted to review that is because where they attach together, we get that angle of Louis. So if you take your finger in your jugular notch and slide it down, you'll feel where the manubrium attaches to the body. That's the angle of Louis. Does anybody remember what that is for? If you come out, you were on which rib? Rib number 2. And that's where you can get all your valve sounds for the heart from. If you don't remember that, I would totally go and review it from last semester. Okay? So angle of Louis, body. Coming down to the bottom part of the breastplate is the xiphoid. Okay? The xiphoid is the bottom part that is somewhat pointed, not real pointy. It's a site of attachment for muscles. It doesn't fully ossify until somebody is 40. And there are some people who ossifies a little bit forward. Okay, when my little guy, my little 1.5-year-old stretches, I can actually see it stretching out. Okay, because his muscles pull up on it and you can see it pop right out. It's kind of an interesting little thing. Okay, so those are the 3 different parts of the breastbone. Okay, 12 pairs of ribs. We talked about all of these. Pairs 1 through 7, also known as vertebrosternal, because they're attached right to the sternum. Okay. Pairs 8 through 12 are false ribs. 8 through 10 also called vertebrochondral, because they attach to that costochondral cartilage. Okay. So that cartilage is called costo, meaning ribs. Chondral is hyaline cartilage. So those are called vertebrochondral ribs, but the cartilage is called costochondral cartilage. Okay? Pairs 11 through 12 are floating. There's no attachment to the sternum. Different parts of the rib. There's the head, which is the part that attaches to the vertebral body. This is really hard to envision. There's the neck. There's a tubercle, which attaches to the transverse process. I'm buzzing through this because I want to show it to you actually on a picture. Okay? And then there's the shaft that comes around. Okay? So the head will be right here. There's a tubercle which will attach to the transverse process of the vertebra. I'm going to show this to you in lab. I know this is hard to see here. Okay? And then the shaft is the part that comes around. Okay? There's a little part on the bottom called the costal groove. And in that costal groove at the bottom, we have intercostal vein, artery, and nerve. If we remember that from last semester, that's important because you don't want to stick a needle on the underside of a rib. You can damage those. Oh, this is a better picture. Here we go. So here's the head, and you can see that articulates or presses right onto the body of the vertebra. Okay. Here's the tubercle. The tubercle presses up to this aspect of the transverse process, and then the shaft is the rest, This would be the neck that's between the head and the tubercle. Okay, this is a much better picture. Okay, pectoral or shoulder girdle is going to consist of the scapula, which is the wing bone, okay, in the back, and the collarbone, also known as the clavicle, is your shoulder girdle. Your shoulder girdle, we're going to talk in about 3 or 4 weeks about the muscles that attach to the shoulder girdle. There's a lot of movement with the shoulder girdle, okay? Because you have a lot of movement, you're also more prone to injuries. And that's why so often we hear about rotator cuff injuries. We're going to absolutely review all that. Okay, so scapula and clavicle is what I want you to know for now. The scapula, there are a couple parts of the scapula that I would like you to know. Excuse me. This is the front of the scapula. This would be the part that would be touching my back. So it would be on the back of my ribs back here. Okay? This would be as if you're looking at somebody's back. This would be the back part of the scapula. And if you palpate and feel along your back here, you can feel what's called the spine of the scapula, okay? The spine of the scapula is important because above it and below it, we actually have the rotator cuff muscles. There are 4 of them, okay? So above and below, we have the rotator cuff muscles. So this is a great landmark to know that. And we'll go over those rotator cuff muscles in a couple weeks. If you follow the spine of the scapula out to the tip, that's called the acromion, okay? The acromion is very important because it actually touches the clavicle in the front. You can see the acromion here, okay? That touches the clavicle. This is an area that if somebody falls very hard on their shoulder, they can actually disarticulate the acromion from the clavicle, okay? The coracoid process is going to be the site of attachment for the bicipital muscle, one part of the bicipital muscle, okay? And then you can see there's superior borders, there's a medial, there's a lateral border, okay? And there's different what are called fossa. Fossa is like a caved-in portion of a bone. Quite often in a fossa, you'll have muscles that are attached in that area, okay? Here's a lateral view. The reason I want to show you this lateral view, so this would be the back, this would be the front that would be touching your ribs. This part that we're looking at is actually the lateral aspect of the scapula. This area is called the glenoid fossa. This is important because the head of the humerus, or the upper arm bone, sits right in that glenoid fossa. It's securely held in place with muscles, okay, and some ligaments. Some tendons, I should say, okay, that keep it stable in that glenoid fossa, okay? Your book says glenoid cavity, either one's appropriate, okay? Fossa, once again, is an indentation. Humerus is going to be the arm bone. The head of the humerus is going to be the area that will sit into the glenoid fossa. The greater and the lesser tubercle are going to be, once again, raised areas of a bone. A tubercle is a raised area of bone. This is going to be the site of attachment for your rotator cuff muscles, okay? So if we're looking at this bone on this side, this is the front of the bone. The greater tubercle is going to be in the superior lateral aspect. The lesser tubercle is actually towards the front. They're called greater and lesser because of the size difference. It's not a huge size difference, but it is, okay? And the biceps is going to run right in between them, one of the heads of the biceps. There's actually 2 heads. That's why it's called biceps. Okay? Excuse me. A forearm. Okay? We've got the radius and the ulna in the forearm. Don't forget, and this is important, especially for these 2 bones, that when we're talking about the placement of these bones, you're referencing anatomical position. So you'd be standing up, feet forward, thumbs out to the side. Towards the thumb is the radius. Towards the medial aspect is the ulna. Okay, so we have 2 forearm bones, radius and ulna. Okay, the radius has a rounded head. Okay, they both have styloid processes. Once again, let's take a closer look here. Okay, and if you can't see this well enough at home, please pause this and pull out a picture from your book. Okay. You can see the radial head is that rounded portion that sits nicely into the top part, or the more proximal part of the ulna, okay? Distally, or towards the bottom of your screen, you can see they both have styloid processes. Okay, so there's a styloid process of the ulna, there's a styloid process of the radius. Those fit around the wrist bones very nice and securely and give a good connection between the forearm bones and the carpal bones, which are the bones of the wrist. Okay, they're held together with a membrane, you can see, and there are also muscles that surround them. The last thing I'd like to show you, if you look at the top right picture, is the olecranon process. The olecranon process is on the ulna, and it's the point of the elbow, which I'm going to bring you back out and show you on me. Okay, so the point of your elbow is the olecranon process. Okay. Hand, we are not, I don't torture you with all the bones of the hand. If you end up going into a practice that specializes in hand surgery, you will have to memorize them, okay? Email me and I'll send you the mnemonic to remember them. But the bones that are in the wrist itself, okay, in this region, are called the carpals. They're a series of 8 small squarish bones, okay, not really squarish, but they're resembling squares, in the bottom part of the palm, okay? The metacarpals are longer bones, which are going to be in this area of the palm, okay? And the phalanges, or the digits, are your fingers. I think one important thing to know is in index, middle, ring, and pinky, you have 3. In thumb, you only have 2 bones, okay? Pelvic girdle. So the pelvic girdle is obviously going to be the pelvis, and that also starts as several different bones which fuse together, okay? If you're talking about one half of the pelvis, it's called the os coxa, okay? And I'll show this to you in lab. I think it's a little easier to understand because you actually have 3 bones that are put together. You have the right os coxa, the left os coxa, and then your sacrum. And they form this nice, complete, what's called bony pelvis, okay? They attach the lower limbs to the axial skeleton, very strong attachments. So you have a lot of movement in the hip, okay? But that bony pelvis is very securely held together, okay? So each hip bone is comprised of the ilium, the ischium, and the pubis. I'll show that to you on a picture. And then they come together with the sacrum and the coccyx in the back, okay? So here we go. Here are those different bones. The ilium, okay, is going to be this curved area down to this rounded hole. This is actually an indentation. If you can't visualize this, once again, get your book out and look at the picture. This is called the acetabulum. The acetabulum is where the head of the femur sits into the pelvis bone, okay? So the ilium is going to come down to this region and cover the top part of the, or comprise the top part of the acetabulum, okay? This part towards the front, so this upper part above this hole is called the pubis, and this part that you actually sit upon is the ischium, okay? So each one of these bones starts, embryologically speaking, as 3 separate bones, and then they ossify, and that ossification center moves out until they all fuse together to get that nice solid bony pelvis, okay? So this one half would be an os coxa. It's connected in the front with something called the pubic symphysis. The pubic symphysis is a fibrocartilaginous disc that holds the 2 os coxae together in the front, okay? In the back, we can see it's held together by the sacrum, okay? Between the sacrum and the ilium, we have something called the sacroiliac joint. Okay, whoops, joint. Okay, this joint is a nice solid connection that holds the pelvis together, but there is, I believe, 1 to 2 millimeters of movement. So there's a slight amount of movement, okay? So here's a picture of the bones from the side. Once again, if you can't see this, you know, I'll zoom this in. I think you'll be able to see it. But if you can't, take a look in your book. The reason I like this picture, I don't make you memorize all these things. Some of them I do, some I don't, okay? And we'll go over the specifics of what I want you to know in lab. I'm not going to sit and go over them with you now because we specifically go over them in lab. But you can see this is a great picture that shows you where the ilium is versus the ischium versus the pubis, okay? So they're showing you a picture from the lateral and the medial aspect of the bone. On the left side of the screen is the lateral aspect, pardon me. On the right side is from the medial aspect. You can see those three parts of the bone. Of the pelvic girdle, once again, they start as three individual bones that fuse together. Okay, comparison of male and female pelvis. This is so easy. Okay, so the true pelvis of the female will be wider. Okay, thank goodness, and it gives greater ability for a baby to pass. Okay. Male pelvis is tilted less forward, adapted for supporting a male's heavier build and holding those stronger muscles, okay, in its narrow exit way, per se, if they were to have children, wouldn't work, and it's deeper than a female, okay? The thing I'm going to point out here, and once I show you the picture, it's just so obvious which one's a female and which one's a male. Men's skeletons tend to be bigger, thicker, and bumpier. Okay. The bone's responses to stress or having stressors put on them is to get thicker and stronger. Okay, so male pelvis is going to be thicker, stronger, and bumpier. Let's take a look at the pictures while we're close. Who would you want to push a baby through? The one on the left or the right? Who's wider? A female pelvis. And you could see that difference too also gives the attributes of how a female looks as opposed to a male. The other interesting thing about this, if I have any basketball players in my class, is the wider pelvis on a female. I'm going to back out now that you've seen that, so I could show you something real quick. Okay, I'm going to come over here, and hopefully, yeah, okay. Because women have a wider pelvis, we tend to have a bigger angle coming into the knees. It's called the Q angle. Okay. Because of that, we tend to have more stress on the knees because the knees aren't directly underneath the hip sockets. And that stress gives us more of a chance to tear the ACL, have menisci problems, etc. Okay, so that's called Q angle because of the wider pelvis. Okay, and once again, you could see this is a great picture. You see how that sacrum in a female is pushed back to really open up that true pelvis to make birthing, well, per se easier, okay? And once again, who are you gonna push a baby through, okay? My vote is on the left, okay? Here's a femur. We're gonna study the different specific parts of the femur in lab, okay? What I wanna point out is just a couple quick things here. You've got the head of the femur, okay? The head of the femur sits in the acetabulum of the pelvis. You've got the greater trochanter and the lesser trochanter, okay? So this is looking at the femur from the front. This is looking at the femur from the back. So you can see the greater trochanter is on the lateral aspect. The lesser trochanter is actually towards the back inside, okay? The greater trochanter, you will know that you will use that as a reference point for injection sites. So one way to find it and get familiar with it is to bring your hands to the lateral aspect of your hip joint and to move your leg in and out, and you could feel that greater trochanter rolling underneath your hand, okay, underneath your finger. Just make sure you're down in the hip, okay, you're a little bit further down. I think sometimes we think that the hip is the low back. Patients do this all the time, okay? Hip is here. This is where your hip joint is, okay, so greater trochanter. Shin bones, we've got the tibia and the fibula, okay? Tibia is the weight-bearing shin bone. Fibula is actually non-weight-bearing, and it's the site of attachment for muscles. The tibial tuberosity is an important thing to know because we have all of our quadricep muscles come down, they envelop our kneecap, and they attach to that tibial tuberosity. They also have a membrane between them, and they also have something called a lateral and a medial malleolus. The lateral and the medial malleolus are those bumps of the ankle, okay? Bumps of the ankle. And what they do, just like the styloid processes in the forearm, is they come down around the torso bones and help to create the ankle joint, okay? Once again, I'm not going to make you memorize all the different parts of the foot. I do want you to understand the concepts of tarsals, And the tarsal bones will be these square-like bones towards the back, okay? Calcaneus is going to be actually an important one for you to know. The calcaneus will be the site of the attachment for the Achilles muscle, okay, which helps to provide attachment for the calf muscles. We'll get into that when we talk about muscles a little bit, okay. Metatarsals are going to form the bulk of the foot, and they attach to digits or phalanges, okay, which are our toes. The big toe has 2 bones, just like the thumb. The rest of the toes have 3. 3, if I can count. Okay, 3. Okay. Developmental aspects, fetal skull. So an infant skull has more bones than the adult skull because the adult skull actually fuses together. Skull bones, such as the mandible and frontal bones, are unfused. Okay. In a fetus, they fuse together as we get older. Although the mandible doesn't fuse to the skull. Okay, the mandible is attached by a joint to the skull. Okay, at birth, skull bones are connected by what are called fontanelles. Now, a common layman's term for fontanelles are soft spots. Excuse me. Okay, don't forget the skull starts as a membrane. That membrane starts to ossify in many different centers, and as they start to ossify out, there are areas of membrane that are still left over. Okay, those are known as the soft spots. Okay, there's the anterior, the posterior, there's a sphenoidal, and there's a mastoidal. We're going to look at all of those in lab. They all fuse together generally at birth, except for the anterior. That usually will fuse anywhere between the 1st to 2nd year, I believe. Okay, and you can see a picture of those there. We've got anterior, posterior, sphenoidal, and mastoidal. Okay. At birth, the cranium is huge relative to the face. Okay, and then our face grows into it. At 9 months of age, the cranium is half adult size. That's pretty amazing. Mandible and maxilla are foreshortened and then lengthen with age. The arms and legs grow at a faster rate than the head and trunk, leading to adult proportions. My poor kids are probably going to watch this someday and yell at me. But when my kids were little, like really little, they would lift their arms up and their arms would come to the top of their head because they hadn't grown enough in proportion, when they were outstretched. Now my little guy is starting to get up there, but he's not to the full proportions of being an adult size. Okay. Thoracic and sacral curvatures are obvious at birth. Okay, that nice C-shaped curve. I love this picture coming up. Okay, those are considered primary curves. Thoracic and sacral, you'll see it'll explain it in just a second. Oh, love this picture. Let's zoom in on that. Okay, that little baby. And you could see that curve back. Okay, now if you can imagine this little baby, fast forward a couple months, he starts to lift his head up. And what does he start to get? He starts to get that lordosis, or that curve in the neck. Eventually he'll stand up and walk, and then he gets that nice curve in the low back, which is also known as a lordosis. Oh, love that picture. Okay. So primary curves are going to be those kyphotic curves, okay, in the thoracic and the sacral. Secondary curves are going to be in cervical and lumbar, and they create those lordoses. Okay. Intervertebral old age. Unfortunately, we all get there. Okay. The discs, do you ever notice that as your parents get older, I notice myself already, starting to lose a little bit of height, okay? The intervertebral discs have a fair amount of water. That water over time starts to get pushed out, okay? Starts to get pushed out, and people start to lose height as they age. You can also get what are called microfractures in the vertebra, which will, if you can imagine each vertebra getting a little bit shorter, the entire height of that patient will get a little bit shorter as well. Risk of disc herniations because you're losing water increases. Loss of stature by several centimeters. Wow, several centimeters. It's amazing. By age 55. Those costal cartilages begin to ossify. It makes it a little bit harder to breathe. Costal cartilages actually provide us a little bit of movement in the ribs. Okay, all bones lose mass. The majority of your bone density is established in your early 20s, if not your late teens, okay? Once you hit 30, okay, you start to lose a little bit of bone mass. It's super important to start to fight that by taking calcium, D, magnesium supplements, and also doing weight-bearing exercises. One of our body's responses to stress on the bones is to deposit more bone there. Okay, so if you stress the bones, you're going to deposit more bone in that area. Excuse me. Okay, that's it for the skeleton. Thank you so much. Let me know if you have any questions. The specific parts of the bones that we didn't go over in lecture are going to be gone over either in your prep, so if you have any questions, come see me, and also in lab. Thank you so much and have a great day.